Vision. Guyton and Hall Textbook of Medical Physiology. Chapter 49, pages 613 to 625. This book addresses both the physiology and pathophysiology of our sensory nervous system, ranging from molecular, cellular, and systems to cognitive and behavioral topics. Individual chapters focus on recent advances in specific areas of sensory systems in different model organisms and humans. All chapters represent recent contributions to the rapidly developing field of sensory science. Physical principles of optics. Before it is possible to understand the optical system of the eye, the student must first be thoroughly familiar with the basic principles of optics, including the physics of light refraction, focusing, depth of focus, and so forth. Refraction of light. Refractive index of a transparent substance. Light rays travel through air at about 300,000 kilometers per second, but much more slowly through transparent solids and liquids. The refractive index of a transparent substance is the ratio of the speed of light in air to the speed of light in matter. The refractive index of air itself is 1.00. Thus, if light passes through a certain glass at a speed of 200,000 kilometers per second, the refractive index of that glass is 300,000 divided by 200,000, or 1.50. Refraction of light rays at an interface between two media with different refractive indices. When light rays traveling forward in a beam, as shown in Figure A, strike an interface that is perpendicular to the beam, the rays enter the second medium without deviating from their course. The only effect that occurs is decreased velocity of transmission and shorter wavelength, as shown in the figure by the shorter distances between wave fronts. If the light rays pass through an ungulated interface as shown in Figure B, the rays bend if the refractive indices of the two media are different from each other. In this particular figure, the light rays are leaving air, which has a refractive index of 1.00, and are entering a block of glass having a refractive index of 1.50. When the beam first strikes the ungulated interface, the lower edge of the beam enters the glass ahead of the upper edge. The wave front in the upper portion of the beam continues to travel at a velocity of 300,000 kilometers per second, while that which entered the glass travels at a velocity of 200,000 kilometers per second. This causes the upper portion of the wave front to move ahead of the lower portion, so that the wave front is no longer vertical but ungulated to the right. Because the direction in which light travels is always perpendicular to the plane of the wave front, the direction of travel of the light beam bends downward. This bending of light rays at an ungulated interface is known as refraction. Note particularly that the degree of refraction increases as a function of 1. The ratio of the two refractive indices of the two transparent media and 2. The degree of angulation between the interface and the entering wave front. Note particularly and remember that the degree of refraction increases as a function of the ratio of the two refractive indices of the two transparent media and the degree of angulation between the interface and the entering wave front. Application of refractive principles to lenses. Convex lens focuses light rays. Figure shows parallel light rays entering a convex lens. The light rays passing through the center of the lens strike the lens exactly perpendicular to the lens surface and, therefore, pass through the lens without being refracted. Toward either edge of the lens, however, the light rays strike a progressively more ungulated interface. The outer rays bend more and more toward the center, which is called convergence of the rays. Half the bending occurs when the rays enter the lens, and half as they exit from the opposite side. At this time, the student should pause and analyze why the rays bend toward the center on leaving the lens. Finally, if the lens has exactly the proper curvature, parallel light rays passing through each part of the lens will be bent exactly enough so that all the rays will pass through a single point, which is called the focal point. Application of refractive principles to lenses. Concave lens diverges light rays. Figure shows the effect of a concave lens on parallel light rays. The rays that enter the center of the lens strike an interface that is perpendicular to the beam and, therefore, do not refract. The rays at the edge of the lens enter the lens ahead of the rays in the center. This is opposite to the effect in the convex lens, and it causes the peripheral light rays to diverge from the light rays that pass through the center of the lens. Thus, the concave lens diverges light rays, but the convex lens converges light rays. Application of refractive principles to lenses. Cylindrical lens bends light rays in only one plane. Comparison with spherical lenses. Figure shows both a convex spherical lens and a convex cylindrical lens. Note that the cylindrical lens bends light rays from the two sides of the lens but not from the top or the bottom. That is, bending occurs in one plane but not the other. Thus, parallel light rays are bent to a focal line. Conversely, light rays that pass through the spherical lens are refracted at all edges of the lens, in both planes, toward the central ray, and all the rays come to a focal point. The cylindrical lens is well demonstrated by a test tube full of water. If the test tube is placed in a beam of sunlight and a piece of paper is brought progressively closer to the opposite side of the tube, a certain distance will be found at which the light rays come to a focal line. The spherical lens is demonstrated by an ordinary magnifying glass. If such a lens is placed in a beam of sunlight and a piece of paper is brought progressively closer to the lens, the light rays will impinge on a common focal point at an appropriate distance. Concave cylindrical lenses diverge light rays in only one plane in the same manner that convex cylindrical lenses converge light rays in one plane. Combination of two cylindrical lenses at right angles equals a spherical lens. Figure shows two convex cylindrical lenses at right angles to each other. The vertical cylindrical lens converges the light rays that pass through the two sides of the lens, and the horizontal lens converges the top and bottom rays. Thus, all the light rays come to a single point focus. In other words, two cylindrical lenses crossed at right angles to each other perform the same function as one spherical lens of the same refractive power. A. Focusing of light from a point source to a line focus by a cylindrical lens. B. Two cylindrical convex lenses at right angles to each other, demonstrating that one lens converges light rays in one plane and the other lens converges light rays in the plane at a right angle. The two lenses combined give the same point focuses that obtained with a single spherical convex lens. Focal length of a lens. The distance beyond a convex lens at which parallel rays converge to a common focal point is called the focal length of the lens. The diagram at the top of figure demonstrates this focusing of parallel light rays. In the middle diagram, the light rays that enter the convex lens are not parallel but are diverging because the origin of the light is a point source not far away from the lens itself. Because these rays are diverging outward from the point source, it can be seen from the diagram that they do not focus at the same distance away from the lens as do parallel rays. In other words, when rays of light that are already diverging enter a convex lens, the distance of focus on the other side of the lens is farther from the lens than is the focal length of the lens for parallel rays. The bottom diagram of figure shows light rays that are diverging toward a convex lens that has far greater curvature than that of the other two lenses in the figure. In this diagram, the distance from the lens at which the light rays come to focus is exactly the same as that from the lens in the first diagram, in which the lens is less convex but the rays entering it are parallel. This demonstrates that both parallel rays and diverging rays can be focused at the same distance beyond a lens, provided the lens changes its convexity. The relation of focal length of the lens, distance of the point source of light, and distance of focus is expressed by the following formula, in which f is the focal length of the lens for parallel rays, a is the distance of the point source of light from the lens, and b is the distance of focus on the other side of the lens. Figure. The two upper lenses of this figure have the same focal length, but the light rays entering the top lens are parallel, whereas those entering the middle lens are diverging. The effect of parallel versus diverging rays on the focal distance is shown. The bottom lens has far more refractive power than either of the other two lenses, i.e., has a much shorter focal length, demonstrating that the stronger the lens is, the nearer to the lens the point focus is. Formation of an image by a convex lens. Figure A shows a convex lens with 2 point sources of light to the left. Because light rays pass through the center of a convex lens without being refracted in either direction, the light rays from each point source of light are shown to come to a point focus in the opposite side of the lens directly in line with the point source and the center of the lens. Any object in front of the lens is, in reality, a mosaic of point sources of light. Some of these points are very bright, some are very weak, and they vary in color. Each point source of light on the object comes to a separate point focus on the opposite side of the lens in line with the lens center. If a white sheet of paper is placed at the focus distance from the lens, one can see an image of the object, as demonstrated in figure B. However, this image is upside down with respect to the original object, and the two lateral sides of the image are reversed. This is the method by which the lens of a camera focuses images on film. Figure A. 2-point sources of light focused at two separate points on opposite sides of the lens. B. Formation of an image by a convex spherical lens. Measurement of the refractive power of a lens diopter. The more a lens bends light rays, the greater is its refractive power. This refractive power is measured in terms of diopters. The refractive power in diopters of a convex lens is equal to 1 meter divided by its focal length. Thus, a spherical lens that converges parallel light rays to a focal point 1 meter beyond the lens has a refractive power of +1 diopter, as shown in figure. If the lens is capable of bending parallel light rays twice as much as a lens with a power of +1 diopter, it is said to have a strength of +2 diopters, and the light rays come to a focal point 0.5 meter beyond the lens. A lens capable of converging parallel light rays to a focal point only 10 centimeters, 0.10 meter, beyond the lens has a refractive power of +10 diopters. The refractive power of concave lenses cannot be stated in terms of the focal distance beyond the lens because the light rays diverge, rather than focus to a point. Figure. Effect of lens strength on the focal distance. However, if a concave lens diverges light rays at the same rate that a 1-diopter convex lens converges them, the concave lens is said to have a dioptric strength of 1. Likewise, if the concave lens diverges light rays as much as a +10 diopter lens converges them, this lens is said to have a strength of 10 diopters. Concave lenses neutralize the refractive power of convex lenses. Thus, placing a 1-diopter concave lens immediately in front of a 1-diopter convex lens results in a lens system with zero refractive power. The strengths of cylindrical lenses are computed in the same manner as the strengths of spherical lenses, except that the axis of the cylindrical lens must be stated in addition to its strength. If a cylindrical lens focuses parallel light rays to a line focus 1 meter beyond the lens, it has a strength of +1 diopter. Conversely, if a cylindrical lens of a concave type diverges light rays as much as a +1 diopter cylindrical lens converges them, it has a strength of 1 diopter. If the focused line is horizontal, its axis is said to be 0 degrees. If it is vertical, its axis is 90 degrees. Optical aberration. In optics, aberration is a property of optical systems, such as lenses, that causes light to be spread out over some region of space rather than focused to a point. Aberrations cause the image formed by a lens to be blurred or distorted, with the nature of the distortion depending on the type of aberration. In an imaging system, it occurs when light from one point of an object does not converge into, or does not diverge from, a single point after transmission through the system. Aberrations occur because the simple paraxial theory is not a completely accurate model of the effect of an optical system on light, rather than due to flaws in the optical elements. An image-forming optical system with aberration will produce an image which is not sharp. Makers of optical instruments need to correct optical systems to compensate for aberration. Aberration can be analyzed with the techniques of geometrical optics. With an ideal lens, light from any given point on an object would pass through the lens and come together at a single point in the image plane, or, more generally, the image surface. Real lenses do not focus light exactly to a single point, however, even when they are perfectly made. These deviations from the idealized lens performance are called aberrations of the lens. Aberrations fall into two classes, monochromatic and chromatic. Monochromatic aberrations are caused by the geometry of the lens or mirror and occur both when light is reflected and when it is refracted. They appear even when using monochromatic light, hence the name. Chromatic aberrations are caused by dispersion, the variation of a lens's refractive index with wavelength. Because of dispersion, different wavelengths of light come to focus at different points. Chromatic aberration does not appear when monochromatic light is used. Spherical aberration. In optics, spherical aberration, SA, is a type of aberration found in optical systems that have elements with spherical surfaces. Lenses and curved mirrors are prime examples, because this shape is easier to manufacture. Light rays that strike a spherical surface off-center are refracted or reflected more or less than those that strike close to the center. Figure. On top is a depiction of a perfect lens without spherical aberration. All incoming rays are focused in the focal point. The bottom example depicts a real lens with spherical surfaces, which produces spherical aberration. The different rays do not meet after the lens in one focal point. The further the rays are from the optical axis, The closer to the lens they intersect the optical axis, positive spherical aberration. Drawing is exaggerated. Positive spherical aberration means peripheral rays are bent too much. Negative spherical aberration means peripheral rays are not bent enough. Figure A. Lens without spherical aberration, neutral. B. Lens with negative spherical aberration. C. Lens with positive spherical aberration. There are two types of chromatic aberration: axial, longitudinal, and transverse, lateral. Axial aberration occurs when different wavelengths of light are focused at different distances from the lens, focus shift. Longitudinal aberration is typical at long focal lengths. Transverse aberration occurs when different wavelengths are focused at different positions in the focal plane, because the magnification and/or distortion of the lens also varies with wavelength. Transverse aberration is typical at short focal lengths. The two types of chromatic aberration have different characteristics, and may occur together. Axial CA occurs throughout the image and is specified by optical engineers, optometrists, and vision scientists in diopters. It can be reduced by stopping down, which increases depth of field so that though the different wavelengths focus at different distances, they are still in acceptable focus. Transverse CA does not occur in the center of the image and increases towards the edge. It is not affected by stopping down. Figure. Comparison of an ideal image of a ring, 1, and ones with only axial, 2, and only transverse, 3, chromatic aberration. Optics of the eye. An illustrious man of science, Helmholtz, said, "If an optician sent it to me as an instrument, I should send it back with reproaches for the carelessness of his work and demand the return of my money." The eye is a camera. The eye is a camera. The eye shown in the picture is optically equivalent to an ordinary camera. It has a lens system, a variable aperture system, pupil, and a retina corresponding to film. The lens system of the eye consists of 4 refracting surfaces. 1. The interface between the air and the anterior surface of the cornea. 2. The interface between the posterior surface of the cornea and aqueous moisture. 3. The interface between the aqueous humor and the anterior surface of the lens of the eye, and 4. The interface between the posterior surface of the lens and the vitreous body. The internal air index is 1, cornea, 1.38, aqueous humor, 1.33, lens, average, 1.40, and vitreous body, 1.34. Reduced eye. If all the refractive surfaces of the eye are algebraically added together and then considered to be one single lens, the optics of the normal eye may be simplified and represented schematically as a reduced eye. This is useful in simple calculations. In the reduced eye, a single refractive surface is considered to exist, with its central point 17 mm in front of the retina and a total refractive power of 59 diopters when the lens is accommodated for distant vision. About 2/3 of the 59 diopters of refractive power of the eye is provided by the anterior surface of the cornea, not by the eye lens. The principal reason for this is that the refractive index of the cornea is markedly different from that of air, while the refractive index of the eye lens is not greatly different from the indices of the aqueous humor and vitreous humor. The total refractive power of the internal lens of the eye, as it normally lies in the eye surrounded by fluid on each side, is only 20 diopters, about 1/3 the total refractive power of the eye. But the importance of the internal lens is that, in response to nervous signals from the brain, its curvature can be increased markedly to provide accommodation, which is discussed later in the lecture. Formation of an image on the retina. In the same manner that a glass lens can focus an image on a sheet of paper, the lens system of the eye can focus an image on the retina. The image is inverted and reversed with respect to the object. However, the mind perceives objects in the upright position despite the upside-down orientation on the retina because the brain is trained to consider an inverted image as the normal. If you want to show how an image of object, arrow in this case, is formed on the retina, draw straight lines through the optical center of the reduced eye as shown in the top figure. After that, any lines from any point of object at normal refraction should be drawn from the cornea to a point on the retina, found using a line passing through the optical center, as shown in the lower figure for point B. The top figure shows the principle of forming an image of an object on the retina. The middle figure shows the projection of a single point located infinitely far from the eye, at a distance of more than 6 meters, with emmetropia. The circuit in the bottom picture is incorrect, meaningless. The entire object, in this case, the arrow, cannot be represented in the figure by a single dot. And now, you have to answer the question and write in the chat. I will look and note in the electronic journal who is present at the lecture. If there is no answer, then I will post absence. Accommodation optics of the eye. Accommodation, mammal's eye. Accommodation is the process by which the vertebrate eye changes optical power to maintain a clear image or focus on an object as its distance varies. In this, distances vary for individuals from the far point, the maximum distance from the eye for which a clear image of an object can be seen, to the near point, the minimum distance for a clear image. Accommodation usually acts like a reflex, including part of the accommodation vergence reflex, but it can also be consciously controlled. Mammals, birds, and reptiles vary their eye's optical power by changing the form of the elastic lens using the ciliary body, in humans up to 15 dioptres in the mean. Fish and amphibians vary the power by changing the distance between a rigid lens and the retina with muscles. Fish and amphibians vary the power by changing the distance between a rigid lens and the retina with muscles. Theories of mechanism of the eye. Helmholtz. The most widely held sixth theory of accommodation is that proposed by Hermann von Helmholtz in 1855. When viewing a far object, the circularly arranged ciliary muscle relaxes, allowing the lens zonule and suspensory ligaments to pull on the lens, flattening it. The source of the tension is the pressure that the vitreous and aqueous humors exert outwards onto the sclera. When viewing a near object, the ciliary muscles contract, resisting the outward pressure on the sclera, causing the lens zonule to slacken, which allows the lens to spring back into a thicker, more convex form. Mechanism of accommodation. In children, the refractive power of the lens of the eye can be increased voluntarily from 20 diopters to about 34 diopters, this in an accommodation of 14 diopters. To do this, the shape of the lens is changed from that of a moderately convex lens to that of a very convex lens. The mechanism is as follows. In a young person, the lens is composed of a strong elastic capsule filled with viscous, proteinaceous, but transparent fluid. When the lens is in a relaxed state with no tension on its capsule, it assumes an almost spherical shape, owing mainly to the elastic retraction of the lens capsule. However, as shown in figure, about 70 suspensory ligaments attach radially around the lens, pulling the lens edges toward the outer circle of the eyeball. These ligaments are constantly tensed by their attachments at the anterior border of the choroid and retina. The tension on the ligaments causes the lens to remain relatively flat under normal conditions of the eye. Figure. Mechanism of accommodation, focusing. However, also located at the lateral attachments of the lens ligaments to the eyeball is the ciliary muscle, which itself has two separate sets of smooth muscle fibers, meridional fibers and circular fibers. The meridional fibers extend from the peripheral ends of the suspensory ligaments to the corneoscleral junction. When these muscle fibers contract, the peripheral insertions of the lens ligaments are pulled medially toward the edges of the cornea, thereby releasing the ligament's tension on the lens. The circular fibers are arranged circularly all the way around the ligament attachments so that when they contract, a sphincter-like action occurs, decreasing the diameter of the circle of ligament attachments. This also allows the ligaments to pull less on the lens capsule. Thus, contraction of either set of smooth muscle fibers in the ciliary muscle relaxes the ligaments to the lens capsule, and the lens assumes a more spherical shape, like that of a balloon, because of the natural elasticity of the lens capsule. And now, you have to answer the question and write in the chat. I will look and note in the electronic journal who is present at the lecture. If there is no answer, then I will post absence. Accommodation is controlled by parasympathetic nerves. The ciliary muscle is controlled almost entirely by parasympathetic nerve signals transmitted to the eye through the third cranial nerve from the third nerve nucleus in the brain stem. Stimulation of the parasympathetic nerves contracts both sets of ciliary muscle fibers, which relaxes the lens ligaments, thus allowing the lens to become thicker and increase its refractive power. With this increased refractive power, the eye focuses on objects nearer than when the eye has less refractive power. Consequently, as a distant object moves toward the eye, the number of parasympathetic impulses impinging on the ciliary muscle must be progressively increased for the eye to keep the object constantly in focus. Sympathetic stimulation has an additional effect in relaxing the ciliary muscle, but this effect is so weak that it plays almost no role in the normal accommodation mechanism. Presbyopia. As a person grows older, the lens grows larger and thicker and becomes far less elastic, partly because of progressive denaturation of the lens proteins. The ability of the lens to change shape decreases with age. The power of accommodation decreases from about 14 diopters in a child to less than 2 diopters by the time a person reaches 45 to 50 years. It then decreases to essentially 0 diopters at age 70 years. Thereafter, the lens remains almost totally non-accommodating, a condition known as presbyopia. Once a person has reached the state of presbyopia, each eye remains focused permanently at an almost constant distance. This distance depends on the physical characteristics of each person's eyes. The eyes can no longer accommodate for both near and far vision. To see clearly both in the distance and nearby, an older person must wear bifocal glasses with the upper segment focused for far seeing and the lower segment focused for near seeing. Example for reading. Pupillary diameter. The major function of the iris is to increase the amount of light that enters the eye during darkness and to decrease the amount of light that enters the eye in daylight. The amount of light that enters the eye through the pupil is proportional to the area of the pupil or to the square of the diameter of the pupil. The pupil of the human eye can become as small as about 1.5 mm and as large as 8 mm in diameter. The quantity of light entering the eye can change about 30-fold as a result of changes in pupillary aperture. Pupillary diameter. The major function of the iris is to increase the amount of light that enters the eye during darkness and to decrease the amount of light that enters the eye in daylight. The amount of light that enters the eye through the pupil is proportional to the area of the pupil or to the square of the diameter of the pupil. The pupil of the human eye can become as small as about 1.5 mm and as large as 8 mm in diameter. The quantity of light entering the eye can change about 30-fold as a result of changes in pupillary aperture. Depth of focus of the lens system increases with decreasing pupillary diameter. Figure shows two eyes that are exactly alike except for the diameters of the pupillary apertures. In the upper eye, the pupillary aperture is small, and in the lower eye, the aperture is large. In front of each of these two eyes are two small point sources of light. Light from each passes through the pupillary aperture and focuses on the retina. Consequently, in both eyes, the retina sees two spots of light. In perfect focus. It is evident from the diagrams, however, that if the retina is moved forward or backward to an out-of-focus position, the size of each spot will not change much in the upper eye, but in the lower eye the size of each spot will increase greatly, becoming a blur circle. In other words, the upper lens system has far greater depth of focus than the bottom lens system. Figure. Effect of small, top, and large, bottom, pupillary apertures on depth of focus. Accommodation reflex. The accommodation reflex, or accommodation convergence reflex, is a reflex action of the eye, in response to focusing on a near object, then looking at a distant object, and vice versa, comprising coordinated changes in vergence, lens shape, accommodation, and pupil size. It is dependent on cranial nerve 2, afferent limb of reflex, superior centers, interneuron, and cranial nerve 3, efferent limb of reflex. The change in the shape of the lens is controlled by ciliary muscles inside the eye. Changes in contraction of the ciliary muscles alters the focal distance of the eye, causing nearer or farther images to come into focus on the retina. This process is known as accommodation. The reflex, controlled by the parasympathetic nervous system, involves three responses: pupil constriction, lens accommodation, and convergence. A near object, for example, a computer screen, subtends a large area in the visual field, i.e. the eyes receive light from wide angles. When moving focus from a distant to a near object, the eyes converge. The ciliary muscle constricts, making the lens thicker, shortening its focal length. The pupil constricts in order to prevent strongly diverging light rays hitting the periphery of the cornea and the lens from entering the eye and creating a blurred image. Accommodation reflex. Pathway. Information from the light on each retina is taken to the occipital lobe via the optic nerve and optic radiation, after a synapse in the lateral geniculate body of the posterior thalamus, where it is interpreted as vision. The peristriate area 19 interprets accommodation, and sends signals via the Edinger-Westphal nucleus and the third cranial nerve to the ciliary muscle, the medial rectus muscle and, via parasympathetic fibers, the sphincter pupillae muscle. Pupil constriction and lens accommodation. During the accommodation reflex, the pupil constricts to increase the depth of focus of the eye by blocking the light scattered by the periphery of the cornea. The lens then increases its curvature to become more biconvex, thus increasing refractive power. The ciliary muscles are responsible for the lens accommodation response. Convergence. Convergence is the ability of the eye to simultaneously demonstrate inward rotation of both eyes toward each other. This is helpful in effort to make focus on near objects clearer. 3 reactions occur simultaneously: the eyes adduct, the ciliary muscles contract, and the pupils become smaller. 5. This action involves the contraction of the medial rectus muscles of the 2 eyes and relaxation of the lateral rectus muscles. The medial rectus attaches to the medial aspect of the eye and its contraction adducts the eye. The medial rectus is innervated by motor neurons in the oculomotor nucleus and nerve. Focus on near objects. The refractive index of the eye's cornea lens system allows the eye to produce sharply focused images on the retina. The refractive power resides mainly in the cornea, but the finer changes in refractive power of the eye are achieved by the lens changing its shape. As a distant object is brought closer to the eye, the image moves behind the retina, producing blurring at the retina. This blurring is minimized by squeezing the lens to a more spherical shape, which again moves the image back to the plane of the retina. In order to fixate on a near object, the ciliary muscle contracts around the lens to decrease its diameter and increase its thickness. The suspensory zonule of ZIN relax and the radial tension around the lens is released. This causes the lens to form a more spherical shape, achieving greater refractive power. 6. Focus on distant objects. When the eye focuses on distant objects, the lens holds itself in a flattened shape due to traction from the suspensory ligaments. Ligaments pull the edges of the elastic lens capsule towards the surrounding ciliary body and, by opposing the internal pressure within the elastic lens, keep it relatively flattened. When viewing a distant object, the ciliary muscle relaxes, the diameter of the lens increases and its thickness decreases. The tension along the suspensory ligaments is increased to flatten the lens and decrease the curvature and achieve a lower refractive power. Refractive error. Refractive error, also known as refraction error, is a problem with focusing light accurately on the retina due to the shape of the eye and/or cornea. The most common types of refractive error are nearsightedness, farsightedness, astigmatism, and presbyopia. Nearsightedness results in far-away objects being blurry, farsightedness and presbyopia result in close objects being blurry, and astigmatism causes objects to appear stretched out or blurry. Other symptoms may include double vision, headaches, and eye strain. Figure. Parallel light rays focus on the retina in emetropia, behind the retina in hyperopia, and in front of the retina in myopia. Emetropia, normal vision. As shown in figure, the eye is considered to be normal, or emtropic, if parallel light rays from distant objects are in sharp focus on the retina when the ciliary muscle is completely relaxed. This means that the emtropic eye can see all distant objects clearly with its ciliary muscle relaxed. However, to focus objects at close range, the eye must contract its ciliary muscle and thereby provide appropriate degrees of accommodation. Myopia, nearsightedness. In myopia, or nearsightedness, when the ciliary muscle is completely relaxed, the light rays coming from distant objects are focused in front of the retina, as shown in the figure. This is usually due to too long an eyeball. But it can result from too much refractive power in the lens system of the eye. No mechanism exists by which the eye can decrease the strength of its lens to less than that which exists when the ciliary muscle is completely relaxed. A myopic person has no mechanism by which to focus distant objects sharply on the retina. However, as an object moves nearer to the person's eye, it finally gets close enough that its image can be focused. Then, when the object comes still closer to the eye, the person can use the mechanism of accommodation to keep the image focused clearly. A myopic person has a definite limiting far point for clear vision. Hyperopia, farsightedness. Hyperopia, which is also known as farsightedness, is usually due to either an eyeball that is too short or, occasionally, a lens system that is too weak. In this condition, as seen in the figure, parallel light rays are not bent sufficiently by the relaxed lens system to come to focus by the time they reach the retina. To overcome this abnormality, the ciliary muscle must contract to increase the strength of the lens. By using the mechanism of accommodation, a farsighted person is capable of focusing distant objects on the retina. If the person has used only a small amount of strength in the ciliary muscle to accommodate for the distant objects, he or she still has much accommodative power left, and objects closer and closer to the eye can also be focused sharply until the ciliary muscle has contracted to its limit. Presbyopic, farsightedness. In old age, when the lens becomes presbyopic, a farsighted person is often unable to accommodate the lens sufficiently to focus even distant objects, much less near objects. A person with presbyopia cannot easily read the small print of an ingredients list, top, compared to someone without presbyopia, bottom. Correction of myopia and hyperopia by use of lenses. It will be recalled that light rays passing through a concave lens diverge. If the refractive surfaces of the eye have too much refractive power, as in myopia, this excessive refractive power can be neutralized by placing in front of the eye a concave spherical lens, which will diverge rays. Such correction is demonstrated in the upper diagram of figure. Conversely, in a person who has hyperopia, that is, someone who has too weak a lens system, the abnormal vision can be corrected by adding refractive power using a convex lens in front of the eye. This correction is demonstrated in the lower diagram of figure. One usually determines the strength of the concave or convex lens needed for clear vision by trial and error, that is, by trying first a strong lens and then a stronger or weaker lens until the one that gives the best visual acuity is found. Astigmatism. Astigmatism is a refractive error of the eye that causes the visual image in one plane to focus at a different distance from that of the plane at right angles. This most often results from too great a curvature of the cornea in one plane of the eye. An example of an astigmatic lens would be a lens surface like that of an egg lying sidewise to the incoming light. The degree of curvature in the plane through the long axis of the egg is not nearly as great as the degree of curvature in the plane through the short axis. Because the curvature of the astigmatic lens along one plane is less than the curvature along the other plane, light rays striking the peripheral portions of the lens in one plane are not bent nearly as much as the rays striking the peripheral portions of the other plane. Correction of astigmatism with a cylindrical lens. The light rays in the vertical plane, indicated by plane BD, are refracted greatly by the astigmatic lens because of the greater curvature in the vertical direction than in the horizontal direction. By contrast, the light rays in the horizontal plane, indicated by plane AC, are not bent nearly as much as the light rays in vertical plane BD. It is obvious that light rays passing through an astigmatic lens do not all come to a common focal point, because the light rays passing through one plane focus far in front of those passing through the other plane. The accommodative power of the eye can never compensate for astigmatism because, during accommodation, the curvature of the eye lens changes approximately equally in both planes. Therefore, in astigmatism, each of the two planes requires a different degree of accommodation. Thus, without the aid of glasses, a person with astigmatism never sees in sharp focus. Figure. Astigmatism, demonstrating that light rays focus at one focal distance in one focal plane, plane AC, and at another focal distance in the plane at a right angle, plane BD. Correction of astigmatism with a cylindrical lens. One may consider an astigmatic eye as having a lens system made up of two cylindrical lenses of different strengths and placed at right angles to each other. To correct for astigmatism, the usual procedure is to find a spherical lens by trial and error that corrects the focus in one of the two planes of the astigmatic lens. Then an additional cylindrical lens is used to correct the remaining error in the remaining plane. To do this, both the axis and the strength of the required cylindrical lens must be determined. There are several methods for determining the axis of the abnormal cylindrical component of the lens system of an eye. One of these methods is based on the use of parallel black bars of the type shown in figure. Some of these parallel bars are vertical, some horizontal, and some at various angles to the vertical and horizontal axis. After placing various spherical lenses in front of the astigmatic eye, a strength of lens is usually found that causes sharp focus of one set of parallel bars but does not correct the fuzziness of the set of bars at right angles to the sharp bars. It can be shown from the physical principles of optics discussed earlier in this chapter that the axis of the out-of-focus cylindrical component of the optical system is parallel to the bars that are fuzzy. Once this axis is found, the examiner tries progressively stronger and weaker positive or negative cylindrical lenses. the axes of which are placed in line with the out-of-focus bars, until the patient sees all the crossed bars with equal clarity. When this has been accomplished, the examiner directs the optician to grind a special lens combining both the spherical correction and the cylindrical correction at the appropriate axis. And now, you have to answer the question and write in the chat. I will look and note in the electronic journal who is present at the lecture. If there is no answer, then I will post absence. Correction of abnormalities by use of contact lenses. Glass or plastic contact lenses can be inserted that fit snugly against the anterior surface of the cornea. These lenses are held in place by a thin layer of tear fluid that fills the space between the contact lens and the anterior eye surface. A special feature of the contact lens is that it nullifies almost entirely the refraction that normally occurs at the anterior surface of the cornea. The reason for this is that the tears between the contact lens and the cornea have a refractive index almost equal to that of the cornea, so that the anterior surface of the cornea no longer plays a significant role in the eye's optical system. Instead, the outer surface of the contact lens plays the major role. History. Origins and first functional prototypes. Leonardo da Vinci is frequently credited with introducing the idea of contact lenses in his 1508 Codex of the Eye, Manual D, wherein he described a method of directly altering corneal power by either submerging the head in a bowl of water or wearing a water-filled glass hemisphere over the eye. Neither idea was practically implementable in da Vinci's time. He did not suggest his idea be used for correcting vision, he was more interested in exploring mechanisms of accommodation. Correction of refractive error. Corrective contact lenses are designed to improve vision, most commonly by correcting refractive error. This is done by directly focusing light so it enters the eye with the proper power for clear vision. A spherical contact lens bends light evenly in every direction, horizontally, vertically, etc. They are typically used to correct myopia and hypermetropia. There are two ways that contact lenses can correct astigmatism. One way is with toric soft lenses that work essentially the same way as eyeglasses with cylindrical correction. A toric lens has a different focusing power horizontally than vertically, and as a result can correct for astigmatism. Another way is by using a rigid gas-permeable lens. Since most astigmatism is caused by the shape of the cornea, rigid lenses can improve vision because the front surface of the optical system is the perfectly spherical lens. Both approaches have advantages and drawbacks. Toric lenses must have the proper orientation to correct for astigmatism, so such lenses must have additional design characteristics to prevent them from rotating out of alignment. This can be done by weighting the bottom of the lens or by using other physical characteristics to rotate the lens back into position, but these mechanisms rarely work perfectly, so some misalignment is common and results in somewhat imperfect correction, and blurring of sight after blinking rotates the lens. Toric soft lenses have all the advantages of soft lenses in general, which are low initial cost, ease of fitting, and minimal adjustment period. Rigid gas-permeable lenses usually provide superior optical correction, but have become less popular relative to soft lenses due to higher initial costs, longer initial adjustment period, and more involved fitting. Correction of presbyopia. Correction of presbyopia, a need for a reading prescription different from the prescription needed for distance, presents an additional challenge in the fitting of contact lenses. Two main strategies exist: multifocal lenses and monovision. Multifocal contact lenses, e.g. bifocals or progressives, are comparable to spectacles with bifocals or progressive lenses because they have multiple focal points. Multifocal contact lenses are typically designed for constant viewing through the center of the lens, but some designs do incorporate a shift in lens position to view through the reading power, similar to bifocal glasses. Monovision is the use of single-vision lenses, one focal point per lens, to focus an eye, typically the dominant one, for distance vision and the other for near work. The brain then learns to use this setup to see clearly at all distances. A technique called modified monovision uses multifocal lenses and also specializes one eye for distance and the other for near, thus gaining the benefits of both systems. Care is advised for persons with a previous history of strabismus and those with significant phorias, who are at risk of eye misalignment under monovision. Studies have shown no adverse effect to driving performance in adapted monovision contact lens wearers. Alternatively, a person may simply wear reading glasses over their distance contact lenses. Cataracts. Cataracts are an especially common eye abnormality that occurs mainly in older people. A cataract is a cloudy or opaque area or areas in the lens. In the early stage of cataract formation, the proteins in some of the lens fibers become denatured. Later, these same proteins coagulate to form opaque areas in place of the normal transparent protein fibers. When a cataract has obscured light transmission so greatly that it seriously impairs vision, the condition can be corrected by surgical removal of the lens. When this is done, the eye loses a large portion of its refractive power, which must be replaced by a powerful convex lens in front of the eye. Usually, however, an artificial plastic lens is implanted in the eye in place of the removed lens. Determination of distance of an object from the eye. Depth perception. A person normally perceives distance by three major means. 1. The sizes of the images of known objects on the retina. 2. The phenomenon of moving parallax. And 3. The phenomenon of stereo size. This ability to determine distance is called depth perception. Determination of distance by sizes of retinal images of known objects. If one knows that a person being viewed is 6 feet tall, one can determine how far away the person is simply by the size of the person's image on the retina. One does not consciously think about the size, but the brain has learned to calculate automatically from image sizes the distances of objects when the dimensions are known. Determination of distance by moving parallax. Another important means by which the eyes determine distance is that of moving parallax. If an individual looks off into the distance with the eyes completely still, he or she perceives no moving parallax, but when the person moves his or her head to one side or the other, the images of close-by objects move rapidly across the retinas, while the images of distant objects remain almost completely stationary. For instance, by moving the head 1 inch to the side when the object is only 1 inch in front of the eye, the image moves almost all the way across the retinas, whereas the image of an object 200 feet away from the eyes does not move perceptibly. Thus, by using this mechanism of moving parallax, one can tell the relative distances of different objects even though only one eye is used. Determination of distance by stereo size binocular vision. Another method by which one perceives parallax is that of binocular vision. Because one eye is a little more than 2 inches to one side of the other eye, the images on the two retinas are different from each other. For instance, an object 1 inch in front of the nose forms an image on the left side of the retina of the left eye but on the right side of the retina of the right eye, whereas a small object 20 feet in front of the nose has its image at closely corresponding points in the centers of the two retinas. This type of parallax is demonstrated in figure, which shows the images of a red spot and a yellow square actually reversed on the two retinas because they are at different distances in front of the eyes. This gives a type of parallax that is present all the time when both eyes are being used. It is almost entirely this binocular parallax, or stereo size, that gives a person with two eyes far greater ability to judge relative distances when objects are nearby than a person who has only one eye. However, stereo size is virtually useless for depth perception at distances beyond 50 to 200 feet. Figure. Perception of distance, 1. By the size of the image on the retina and, 2. As a result of stereo size. Ophthalmoscope. The ophthalmoscope is an instrument through which an observer can look into another person's eye and see the retina with clarity. Although the ophthalmoscope appears to be a relatively complicated instrument, its principles are simple. The basic components are shown in figure and can be explained as follows. If a bright spot of light is on the retina of an emmetropic eye, light rays from this spot diverge toward the lens system of the eye. After passing through the lens system, they are parallel with one another because the retina is located one focal length distance behind the lens system. Then, when these parallel rays pass into an emmetropic eye of another person, they focus again to a point focus on the retina of the second person, because his or her retina is also one focal length distance behind the lens. Any spot of light on the retina of the observed eye projects to a focal spot on the retina of the observing eye. Figure. Optical system of the ophthalmoscope. Thus, if the retina of one person is made to emit light, the image of his or her retina will be focused on the retina of the observer, provided the two eyes are emmetropic and are simply looking into each other. To make an ophthalmoscope, one need only devise a means for illuminating the retina to be examined. Then, the reflected light from that retina can be seen by the observer simply by putting the two eyes close to each other. To illuminate the retina of the observed eye, An ungulated mirror or a segment of a prism is placed in front of the observed eye in such a manner, as shown in figure, that light from a bulb is reflected into the observed eye. Thus, the retina is illuminated through the pupil, and the observer sees into the subject's pupil by looking over the edge of the mirror or prism or through an appropriately designed prism. It is clear that these principles apply only to people with completely emmetropic eyes. If the refractive power of either the observed eye or the observer's eye is abnormal, it is necessary to correct the refractive power for the observer to see a sharp image of the observed retina. The usual ophthalmoscope has a series of very small lenses mounted on a turret so that the turret can be rotated from one lens to another until the correction for abnormal refraction is made by selecting a lens of appropriate strength. In normal young adults, natural accommodative reflexes occur that cause an approximate +2 diopter increase in strength of the lens of each eye. To correct for this, it is necessary that the lens turret be rotated to approximately 4 diopter correction. Fluid system of the eye. Intraocular fluid. Fluid system of the eye. Intraocular fluid. The eye is filled with intraocular fluid, which maintains sufficient pressure in the eyeball to keep it distended. Figure demonstrates that this fluid can be divided into two portions: aqueous humor, which lies in front of the lens, and vitreous humor, which is between the posterior surface of the lens and the retina. The aqueous humor is a freely flowing fluid, whereas the vitreous humor, sometimes called the vitreous body, is a gelatinous mass held together by a fine fibrillar network composed primarily of greatly elongated proteoglycan molecules. Both water and dissolved substances can diffuse slowly in the vitreous humor, but there is little flow of fluid. Aqueous humor is continually being formed and reabsorbed. The balance between formation and reabsorption of aqueous humor regulates the total volume and pressure of the intraocular fluid. Formation of aqueous humor by the ciliary body. Aqueous humor is formed in the eye at an average rate of 2 to 3 microliters each minute. Essentially all of it is secreted by the ciliary processes, which are linear folds projecting from the ciliary body into the space behind the iris where the lens ligaments and ciliary muscle attach to the eyeball. A cross-section of these ciliary processes is shown in Figure A, and their relation to the fluid chambers of the eye can be seen in Figure B. Because of their folded architecture, the total surface area of the ciliary processes is about 6 square centimeters in each eye, a large area, considering the small size of the ciliary body. The surfaces of these processes are covered by highly secretory epithelial cells, and immediately beneath them is a highly vascular area. Aqueous humor is formed almost entirely as an active secretion by the epithelium of the ciliary processes. Secretion begins with active transport of sodium ions into the spaces between the epithelial cells. The sodium ions pull chloride and bicarbonate ions along with them to maintain electrical neutrality. Then all these ions together cause osmosis of water from the blood capillaries lying below into the same epithelial intercellular spaces, and the resulting solution washes from the spaces of the ciliary processes into the anterior chamber of the eye. In addition, several nutrients are transported across the epithelium by active transport or facilitated diffusion. They include amino acids, ascorbic acid, and glucose. Outflow of aqueous humor from the eye. After aqueous humor is formed by the ciliary processes, it first flows, as shown in figure, through the pupil into the anterior chamber of the eye. From here, the fluid flows anterior to the lens and into the angle between the cornea and the iris, then through a meshwork of trabeculae, finally entering the canal of Schlemm, which empties into extraocular veins. Figure demonstrates the anatomical structures at this iridocarneal angle, showing that the spaces between the trabeculae extend all the way from the anterior chamber to the canal of Schlemm. The canal of Schlemm is a thin-walled vein that extends circumferentially all the way around the eye. Its endothelial membrane is so porous that even large protein molecules, as well as small particulate matter up to the size of red blood cells, can pass from the anterior chamber into the canal of Schlemm. Even though the canal of Schlemm is actually a venous blood vessel, so much aqueous humor normally flows into it that it is filled only with aqueous humor rather than with blood. The small veins that lead from the canal of Schlemm to the larger veins of the eye usually contain only aqueous humor, and they are called aqueous veins. Figure. Anatomy of the iridocarneal angle, showing the system for outflow of aqueous humor from the eyeball into the conjunctival veins. Intraocular pressure. The average normal intraocular pressure is about 15 millimeters of mercury, with a range from 12 to 20 millimeters of mercury. Tonometry. Because it is impractical to pass a needle into a patient's eye to measure intraocular pressure, this pressure is measured clinically by using a tonometer, the principle of which is shown in figure. The cornea of the eye is anesthetized with a local anesthetic and the footplate of the tonometer is placed on the cornea. A small force is then applied to a central plunger, causing the part of the cornea beneath the plunger to be displaced inward. The amount of displacement is recorded on the scale of the tonometer, and this is calibrated in terms of intraocular pressure. Regulation of intraocular pressure. Intraocular pressure remains constant in the normal eye, usually within plus or minus 2 mm of mercury of its normal level, which averages about 15 mm of mercury. The level of this pressure is determined mainly by the resistance to outflow of aqueous humor from the anterior chamber into the canal of Schlemm. This outflow resistance results from the meshwork of trabeculae through which the fluid must percolate on its way from the lateral angles of the anterior chamber to the wall of the canal of Schlemm. These trabeculae have minute openings of only 2 to 3 micrometers. The rate of fluid flow into the canal increases markedly as the pressure rises. At about 15 mm of mercury in the normal eye, the amount of fluid leaving the eye by way of the canal of Schlemm usually averages 2.5 ml per min and equals the inflow of fluid from the ciliary body. The pressure normally remains at about this level of 15 mm of mercury. Mechanism for cleansing the trabecular spaces and intraocular fluid. When large amounts of debris are present in the aqueous humor, as occurs after hemorrhage into the eye or during intraocular infection, the debris is likely to accumulate in the trabecular spaces leading from the anterior chamber to the canal of Schlemm. This debris can prevent adequate reabsorption of fluid from the anterior chamber, sometimes causing glaucoma, as explained subsequently. However, on the surfaces of the trabecular plates are large numbers of phagocytic cells. Immediately outside the canal of Schlemm is a layer of interstitial gel that contains large numbers of reticuloendothelial cells that have an extremely high capacity for engulfing debris and digesting it into small molecular substances that can then be absorbed. Thus, this phagocytic system keeps the trabecular spaces cleaned. The surface of the iris and other surfaces of the eye behind the iris are covered with an epithelium that is capable of phagocytizing proteins and small particles from the aqueous humor, thereby helping to attain a clear fluid. Glaucoma, a principal cause of blindness. Glaucoma is one of the most common causes of blindness. It is a disease of the eye in which the intraocular pressure becomes pathologically high, sometimes rising acutely to 60 to 70 mm of mercury. Pressures above 25 to 30 mm of mercury can cause loss of vision when maintained for long periods. Extremely high pressures can cause blindness within days or even hours. As the pressure rises, the axons of the optic nerve are compressed where they leave the eyeball at the optic disc. This compression is believed to block axonal flow of cytoplasm from the retinal neuronal cell bodies into the optic nerve fibers leading to the brain. The result is lack of appropriate nutrition of the fibers, which eventually causes death of the involved fibers. It is possible that compression of the retinal artery, which enters the eyeball at the optic disc, also adds to the neuronal damage by reducing nutrition to the retina. In most cases of glaucoma, the abnormally high pressure results from increased resistance to fluid outflow through the trabecular spaces into the canal of Schlemm at the iridocorneal junction. For instance, in acute eye inflammation, white blood cells and tissue debris can block these trabecular spaces and cause an acute increase in intraocular pressure. In chronic conditions, especially in older individuals, fibrous occlusion of the trabecular spaces appears to be the likely culprit. Glaucoma can sometimes be treated by placing drops in the eye that contain a drug that diffuses into the eyeball and reduces the secretion or increases the absorption of aqueous humor. When drug therapy fails, operative techniques to open the spaces of the trabeculae or to make channels to allow fluid to flow directly from the fluid space of the eyeball into the subconjunctival space outside the eyeball can often effectively reduce the pressure. Visual acuity. Visual acuity, VA, commonly refers to the clarity of vision, but technically rates a person's ability to recognize small details with precision. Visual acuity depends on optical and neural factors. Optical factors of the eye influence the sharpness of an image on its retina. Neural factors include the health and functioning of the retina, of the neural pathways to the brain, and of the interpretative faculty of the brain. The most commonly referred to visual acuity is distance acuity or far acuity, for example, 20/20ths vision, which describes someone's ability to recognize small details at a far distance. This ability is compromised in people with myopia, also known as short-sightedness or nearsightedness. Another visual acuity is near acuity, which describes someone's ability to recognize small details at a near distance. This ability is compromised in people with hyperopia, also known as long-sightedness or far-sightedness. A common optical cause of low visual acuity is refractive error, ametropia errors in how the light is refracted in the eyeball. Causes of refractive errors include aberrations in the shape of the eyeball or the cornea, and reduced ability of the lens to focus light. When the combined refractive power of the cornea and lens is too high for the length of the eyeball, the retinal image will be in focus in front of the retina and out of focus on the retina, yielding myopia. A similar poorly focused retinal image happens when the combined refractive power of the cornea and lens is too low for the length of the eyeball except that the focused image is behind the retina, yielding hyperopia. Normal refractive power is referred to as ametropia. Other optical causes of low visual acuity include astigmatism, in which contours of a particular orientation are blurred, and more complex corneal irregularities. Refractive errors can mostly be corrected by optical means, such as eyeglasses, contact lenses, and refractive surgery. For example, in the case of myopia, the correction is to reduce the power of the eye's refraction by a so-called minus lens. Neural factors that limit acuity are located in the retina, in the pathways to the brain, or in the brain. Examples of conditions affecting the retina include detached retina and macular degeneration. Examples of conditions affecting the brain include amblyopia, caused by the visual brain not having developed properly in early childhood, and by brain damage, such as from traumatic brain injury or stroke. When optical factors are corrected for, acuity can be considered a measure of neural functioning. Visual acuity is typically measured while fixating, i.e. as a measure of central, or foveal, vision, for the reason that it is highest in the very center. However, acuity in peripheral vision can be of equal importance in everyday life. Acuity declines towards the periphery first steeply and then more gradually, in an inverse linear fashion. The decline follows approximately a hyperbola. At 2 degrees eccentricity, for example, acuity is half the foveal value. Visual acuity is a measure of how well small details are resolved in the very center of the visual field. It therefore does not indicate how larger patterns are recognized. Visual acuity alone thus cannot determine the overall quality of visual function. Visual acuity. Theoretically, light from a distant point source, when focused on the retina, should be infinitely small. However, because the lens system of the eye is never perfect, such a retina spot ordinarily has a total diameter of about 11 micrometers, even with maximal resolution of the normal eye optical system. The spot is brightest in its center and shades off gradually toward the edges, as shown by the 2-point images in figure. The average diameter of the cones in the fovea of the retina, the central part of the retina, where vision is most highly developed, is about 1.5 micrometers, which is 1/7 the diameter of the spot of light. Nevertheless, because the spot of light has a bright center point and shaded edges, a person can normally distinguish 2 separate points if their centers lie as much as 2 micrometers apart on the retina, which is slightly greater than the width of a foveal cone. This discrimination between points is also shown in figure. Figure. Maximum visual acuity for 2-point sources of light. The normal visual acuity of the human eye for discriminating between point sources of light is about 25 seconds of arcade. That is, when light rays from 2 separate points strike the eye with an angle of at least 25 seconds between them, they can usually be recognized as 2 points instead of 1. This means that a person with normal visual acuity looking at 2 bright pinpoint spots of light 10 meters away can barely distinguish the spots as separate entities when they are 1.5 to 2 millimeters apart. The fovea is less than 0.5 millimeter, less than 500 micrometers, in diameter, which means that maximum visual acuity occurs in less than 2 degrees of the visual field. Outside this foveal area, the visual acuity becomes progressively poorer, decreasing more than tenfold as the periphery is approached. This is caused by the connection of more and more rods and cones to each optic nerve fiber in the nonfoveal, more peripheral parts of the retina. Clinical method for stating visual acuity. The chart for testing eyes usually consists of letters of different sizes placed 20 feet away from the person being tested. If the person can see well the letters of a size that he or she should be able to see at 20 feet, the person is said to have 20/20ths vision, that is, normal vision. If the person can see only letters that he or she should be able to see at 200 feet, the person is said to have 20/200 vision. In other words, the clinical method for expressing visual acuity is to use a mathematical fraction that expresses the ratio of two distances, which is also the ratio of one's visual acuity to that of a person with normal visual acuity. Eye examination for visual acuity. Visual acuity is a measure of the spatial resolution of the visual processing system. VA, as it is sometimes referred to by optical professionals, is tested by requiring the person whose vision is being tested to identify so-called optotypes, stylized letters, land-old rings, pediatric symbols, symbols for the illiterate, standardized Cyrillic letters in the Golovine, SIVSAFE table, or other patterns, on a printed chart, or some other means, from a set viewing distance. Optotypes are represented as black symbols against a white background, i.e. at maximum contrast. The distance between the person's eyes and the testing chart is set so as to approximate optical infinity in the way the lens attempts to focus, far acuity, or at a defined reading distance, near acuity. A reference value above which visual acuity is considered normal is called 6/6ths vision, the USC equivalent of which is 20/20ths vision, at 6 meters or 20 feet. A human eye with that performance is able to separate contours that are approximately 1.75 millimeters apart. Vision of 6/12ths corresponds to lower performance, while vision of 6/3 to better performance. Normal individuals have an acuity of 6/4ths or better, depending on age and other factors. In the expression 6/x vision, the numerator, 6, is the distance in meters between the subject and the chart, and the denominator, x, the distance at which a person with 6/6ths acuity would discern the same optotype. Thus, 6/12ths means that a person with 6/6ths vision would discern the same optotype from 12 meters away, for example at twice the distance. This is equivalent to saying that with 6/12ths vision, the person possesses half the spatial resolution and needs twice the size to discern the optotype. A simple and efficient way to state acuity is by converting the fraction to a decimal. 6/6ths then corresponds to an acuity, or a visus, of 1.0, see expression below, while 6/3 corresponds to 2.0, which is often attained by well-corrected healthy young subjects with binocular vision. Stating acuity as a decimal number is the standard in European countries, as required by the European norm, and ISO 8596, previously DIN 58220. The precise distance at which acuity is measured is not important as long as it is sufficiently far away and the size of the optotype on the retina is the same. That size is specified as a visual angle, which is the angle, at the eye, under which the optotype appears. For 6/6ths equals 1.0 acuity, the size of a letter on the Snellen chart or Landolt C chart is a visual angle of 5 arcminutes, 1 arcmin equals 1/60th of a degree. By the design of a typical optotype, like a Snellen E or a Landolt C, the critical gap that needs to be resolved is 1/5 this value, for example, 1 arcmin. The latter is the value used in the international definition of visual acuity. Acuity equals 1/gap size arcmin. Acuity is a measure of visual performance and does not relate to the eyeglass prescription required to correct vision. Instead, an eye exam seeks to find the prescription that will provide the best corrected visual performance achievable. The resulting acuity may be greater or less than 6/6ths equals 1.0. Indeed, a subject diagnosed as having 6/6ths vision will often actually have higher visual acuity because, once this standard is attained, the subject is considered to have normal, in the sense of undisturbed, vision, and smaller optotypes are not tested. Subjects with 6/6ths vision or better, 20/15ths, 20/10ths, etc., may still benefit from an eyeglass correction for other problems related to the visual system, such as hyperopia, ocular injuries, or presbyopia. Measurement. Visual acuity is measured by a psychophysical procedure and as such relates the physical characteristics of a stimulus to a subject's percept and their resulting responses. Measurement can be by using an eye chart invented by Ferdinand Monnoyer, by optical instruments, or by computerized tests like the FRACT. Care must be taken that viewing conditions correspond to the standard, such as correct illumination of the room and the eye chart, correct viewing distance, enough time for responding, error allowance, and so forth. In European countries, These conditions are standardized by the European norm, and ISO 8596, previously DIN 58220. A Snellen chart is an eye chart that can be used to measure visual acuity. Snellen charts are named after the Dutch ophthalmologist Herman Snellen, who developed the chart in 1862 as a measurement tool for the acuity formula developed by his professor Franciscus Cornelis Donders. While alternative versions had been developed before him, by Eduard Jaeger von Jechstel and others, Snellen developed his eye chart in 1862 to measure visual acuity, which rapidly became the global standard. Since its inception, more copies of the Snellen chart have been sold in the United States than any other poster. It remained a ubiquitous standard in medical offices into the 21st century. The normal Snellen chart is printed with 11 lines of block letters. The first line consists of one very large letter, which may be one of several letters, for example E, H, or N. Subsequent rows have increasing numbers of letters that decrease in size. A person taking the test covers one eye from 6 meters or 20 feet away, and reads aloud the letters of each row, beginning at the top. The smallest row that can be read accurately indicates the visual acuity in that specific eye. The symbols on an acuity chart are formally known as optotypes. Variation of Snellen chart with another letter sequence. Australia, 1946. In the case of the traditional Snellen chart, the optotypes have the appearance of block letters, and are intended to be seen and read as letters. They are not, however, letters from any ordinary typographer's font. They have a particular, simple geometry in which the thickness of the lines equals the thickness of the white spaces between lines and the thickness of the gap in the letter C. The height and width of the optotype, letter, is 5 times the thickness of the line. Only the 9 letters C, D, E, F, L, O, P, T, Z are used in the common Snellen chart. The perception of 5 out of 6 letters, or similar ratio, is judged to be the Snellen fraction. Wall-mounted Snellen charts are inexpensive and are sometimes used for approximate assessment of vision, e.g. in a primary care physician's office. Whenever acuity must be assessed carefully, as in an eye doctor's examination, or where there is a possibility that the examinee might attempt to deceive the examiner, as in a motor vehicle license office, equipment is used that can present the letters in a variety of randomized patterns. BS 4274-1:1968, British Standards Institution, Specification for Test Charts for Determining Distance Visual Acuity, was replaced by BS 4274-1:2003, Test Charts for Clinical Determination of Distance Visual Acuity Specification. It states that the luminance of the presentation shall be uniform and not less than 120 CD/M2. Any variation across the test chart shall not exceed 20%. According to BS 4274-1:2003, only the letters C, D, E, F, H, K, N, P, R, U, V, and Z should be used for the testing of vision based upon equal legibility of the letters citation needed. Snellen fraction. Visual acuity is the distance at which test is made / distance at which the smallest optotype identified subtends an angle of 5 arc minutes, and the critical distinguishing features of the optotype subtend an angle of 1 arc minute. Snellen defined standard vision as the ability to recognize one of his optotypes when it's subtended 5 minutes of arcade. Thus the optotype can only be recognized if the person viewing it can discriminate a spatial pattern separated by a visual angle of 1 minute of arc. Outside the United States, the standard chart distance is 6 meters, 20 feet, and normal acuity is designated 6/6. Other acuities are expressed as ratios with a numerator of 6. Some clinics do not have 6-meter eye lanes available, and either a half-size chart subtending the same angles at 3 meters, 9.8 feet, or a reversed chart projected and viewed by a mirror is used to achieve the correct sized letters. In the most familiar acuity test, a Snellen chart is placed at a standard distance, 6 meters. At this distance, the symbols on the line representing normal acuity subtend an angle of 5 minutes of arc, and the thickness of the lines and of the spaces between the lines subtends 1 minute of arc. This line, designated 6/6 or 20/20, is the smallest line that a person with normal acuity can read at a distance of 6 meters. This definition is arbitrary, since human eyes typically have higher acuity. As Turing writes, we have found also that the best eyes have a visual acuity which approaches 2, and we can be almost certain that if, with a good illumination, the acuity is only equal to 1, the eye presents defects sufficiently pronounced to be easily established. 3 lines above, the letters have twice the height of those letters on the 6/6, or 20/20 in the US, line. If this is the smallest line a person can read, the person's acuity is 6/12, 20/40, meaning that this person needs to approach to a distance of 6 meters, 20 feet, to read letters that a person with normal acuity could read at 12 meters, 39 feet. In an even more approximate manner, this person could be said to have half the normal acuity of 6/6. At exactly 6 meters distance from the patient, the letters on the 6/6 line shall subtend 5 minutes of arcade, such that the individual limbs of the letters subtend 1 minute of arcade, which means that the chart should be sized such that these letters are 8.73 millimeters tall and the topmost, 6/60ths, E should be 87.3 millimeters tall. Putting it another way, the eye should be at a distance 68.76 times the height of the top, 6/60ths, letter. The largest letter on an eye chart often represents an acuity of 6/60ths, 20/200, the value that is considered legally blind in the US. Many individuals with high myopia cannot read the large E without glasses, but can read the 6/6ths, 20/20ths, line or 6/4.5, 20/15ths, line with glasses. By contrast, legally blind individuals have a visual acuity of 6/60ths, 20/200, or less when using the best corrective lens. E-chart. An E-chart, also known as a tumbling E-chart, is an ophthalmological chart used to measure a patient's visual acuity. This chart is useful for patients who are unable to read the Latin alphabet, for example, very young children. It is also used in countries where people do not use the alphabet in their native language, for example, in China. It contains rows of the letter E in various kinds of rotation. The patient is asked to state, usually by pointing, where the limbs of the E are pointing, up, down, left or right. Depending on how far the patient can read, his or her visual acuity is quantified. It works on the same principle as Snellen's distant vision chart. Eye specialist carrying out eye examination on a patient at a district hospital in Zambia. Landolt C. The Landolt C, also known as a Landolt ring, Landolt broken ring, or Japanese vision test, is an optotype, a standardized symbol used for testing vision. It was developed by the Swiss-born ophthalmologist Edmond Landolt. The Landolt C consists of a ring that has a gap, thus looking similar to the letter C. The gap can be at various positions, usually left, right, bottom, top and the 45 degrees positions in between, and the task of the tested person is to decide on which side the gap is. The size of the C and its gap are reduced until the subject makes a specified rate of errors. The minimum perceivable angle of the gap is taken as measure of the visual acuity. It is generally practiced in the laboratory. The stroke width is 1/5 of the diameter, and the gap width is the same. This is identical to the letter C from a Snellen chart. The Landolt C is the standard optotype for acuity measurement in most European countries. It was standardized, together with measurement procedures, by the German DIN, as DIN 58220, now an ISO 8596. Golovin, SIVSAFE table. The Golovin, SIVSAFE table is a standardized table for testing visual acuity, which was developed in 1923 by Soviet ophthalmologists Sergei Golovin and D.A. SIVSAFE. In the USSR, it was the most common table of its kind, and as of 2008 its use is still widespread in several post-Soviet states. The table consists of 2 parts with 12 rows each, representing visual acuity values between 0.1 and 2.0. The left part consists of series of the Cyrillic letters, and in a definite order, and the right part of the table consists of a series of Landolt C symbols. The width of each character is equal to its height, and the contours have standard 1/5 gaps of the overall size. The value D, indicated to the left of each row, gives the distance in meters from which a person with a visual acuity of 1.0 can read the corresponding row. The value V, indicated to the right, gives the minimum visual acuity needed to read the row from a distance of 5 meters. The first row contains symbols 70 millimeters in size, V equals 0.1, the second row, 35 millimeters, the bottom third row, 7 millimeters, V equals 1.0, the bottom row, 3.5 millimeters, V equals 2.0. Black and white pattern identification at 1 arcminute angle is considered to be visual acuity of 1.0, which is around 1 mm per 3.44 m distance. A character 7 mm in size has 1.4 mm pattern gaps, so over the 5 m view distance it gives an angle of around 1 arcminutes, at an 0.007/5/5, 0.963. Electronic chart. To ensure adequate illumination of the Snellen charts, various medical device manufacturers had developed Snellen chart products with backlight or projection. Digital chart. Since computer monitors typically have good lighting for reading and LCD/LED monitors have high DPI, between 96 and 480, they are suitable for displaying optotypes. Commonly, digital chart products support randomizing optotypes displayed to prevent patients from cheating through memorizing the chart. In Google Play and App Store, iOS, there are Snellen chart apps for smartphones and tablets.
I hope that the competencies considered will help you to do the practical tasks of the workshop. This will end the lecture.